quick. One. So today's topic is such that when we realize that none of the system is isolated. So we'll be talking about respiratory system, but we'll all the way to autoimmune disorders. Just see some of the X-rays. So that is how it will give you a very fine idea of how the things are really related with each other. So by the time everyone joins, we talk about two important things. One will, where you asked about that you are at times learning and remembering the things, but you forget also. That how to avoid the forgetfulness. This is one. And the second was about the time management. So regarding the time management, how to manage the time, we'll take one extra session on that. Questions of upper limb. Yeah, unfortunately, somehow I have misplaced that file of upper limb. So just give me some time, you'll get it. I'm trying to figure out, because if one of the hard drive, somehow I'm not getting that hard drive, somebody was there. But I'll procure it. So I was a bit busy last 3-4 days, but I'll manage it. Regarding this how to remember the subject. To remember the subject, there is no big rocket science. Just it is what is called as the follow this memory chart. Memory chart means whatever the things which you learn today, this is called as the day 0. Whatever the things which you learn today, if you don't revise it within 24 hours, you'll be losing minimum 40% of the stuff. So this is a big mistake that at times we study and the topic in library or study it, you don't revise it, and after 2-3 days when someone asks the question, you find it so difficult. So what you have to do is day 0, that is in the entire day, whatsoever you have learned, a very high speed revision. This is high speed. That means you don't have to really go line by line, word by word, just go through it before sleep. Just go through whatever you studied in the entire day. So when you go through it, it would be refreshed. This is now day 1. First 3 days will be very important. The best phase is this. As soon as you wake up, just flip those pages or scroll through that file, right? Just 5 minutes, that would be enough. But these two simple things, this one and it is this phase, that will improve your comprehension. That is the ability to understand and remember the subject by more than 5 times. So this is very simple, and this is also called as the sleep learning. So actually, even during your sleep, you are revising it. So this is one. Then don't worry much, because on the day 1, when you go back to your sleep, you are actually revising day 1's topic. Within 3 days, you need one more revision. So how you can really plan is day 0, day 1, day 2, all these things what you have studied, revise it. So this is where you will be requiring some planning, because this will take some time. And every Sunday, if not much, every Sunday, revise previous week's, revise previous week, full. When you do this, it won't take even, is there any brain exercise? Yeah, there are very good brain exercises. We'll talk about it. So let me just finish this part. So revise previous week, full week. So this will take 1 hour. Dedicate this 1 hour. You don't have to go line by line, word by word, just go through it. That would be more than enough to refresh it. Once you do this, then you are safe for at least 1 month. Then comes every month, last Sunday, again it is whatever the time which is comfortable, the entire day, again 1 hour. So at this 1 hour, you'll be doing a monthly revision. You'll find that in all these cases, if you are very regular, on Sunday you are revising, so you'll need only 1 hour for the entire month's revision, because you'll be going so fast, and this is fixed 1 hour. So your brain will be functioning to that level. It will be absorbing to that level because you have fixed 1 hour, and keep it very strict. After 1 hour, so just set an alarm, and within 1 hour, if things are not complete, stop it for at least that point of time. Some other time of the day, finish the rest of the stuff. But when you stop it at this point, exactly after 1 hour, after such 2 or 3 events, your brain would be conditioned. And your brain will be telling that, no, it is in this much time only am I supposed to finish the work, and will work accordingly. This is what is called as the brain plasticity, neuroplasticity. The neuroplasticity is one of the most powerful thing for your brain. And because of young age, so your neurotransmitters, your neuronal system, they are at its best. You asked about, one of the mail, you asked about some food stuff, right? Which are the food which are good? I say just this much. Almonds and walnuts. People say they are so expensive, but you don't have to eat 1 kilogram. Just 5 almonds and 4 halves, right? So actually 2 full walnuts. Soak them in water, right? overnight water for 2 hours. Overnight in water, and next morning just chew them properly. Is almond. Almond is badam. Walnut is akhroot. That's right. Almond is badam. Right. So go for it. In 1 kilogram. I know it costs about 1,000 rupees, or even if you go for the best quality, so that would be much. But it would last how much? 1 kilogram would last for over 1.5 months. So yeah, for any of the disability, because before 6 years, if something has happened, now still if there is a trouble, it has to be checked. But well, any of the hairline fracture will never last for 6 years, right? Unless and until there is so much of malnourishment and the fracture is big. Hairlines, though, they definitely, because in hairline, the thing is that only the cortex, this outer thing is called as the cortex, inner is called as the medulla, right? So this is the cortex which is broken. The cortex is broken, right? And only the hairline fracture. So that means there is no displacement of the broken tissue, broken bone. So if there is no displacement, even if you don't give, plaster is given, but even if the plaster is not given, still person will be fine. So there must be some muscular problem. Should be checked. Can't comment this much. Okay, so this is almonds and walnuts. Just this much. It is really good. More when we'll be regarding the diet, etc. We'll keep one extra session on that. But this much if you start following. This is what is called the memory chart. If you start following this much, you'll find you'll find that it's after 1 month of practice of this, you'll be very happy with yourself. You'll start remembering the things very properly. At the same time, you'll be able to express it in your own words also. Right? On to now the respiratory system. Today we'll be taking the physiology, and then on to that we'll be moving on to the cardiology. Then we'll also take the GIT, and then combining all of them with pathology. Very typical X-ray chest. Today's X-ray chest, it will be having many of the things, but you need to see it carefully, because I now consider that yes, you have got real good grip on the X-ray. So at least the basic things, so you watch it very precisely. Right? There is no chat group. There is no chat group for lecture notes. You just send a mail to me on this email address. I'll send you the link. That is a Google Cloud link. That is where you get all the notes. There is no WhatsApp group. There is nothing. This is the point of contact. You can contact me on this point. Till you are gmail.com. All right. So here is. So this is our action plan for today. What I really want is that as we discuss today, I am expecting the maximum interactive, because I'll keep on asking you that question, so try to answer. So here is the respiratory system, and in respiratory system we have talked about that this is like our heart, right atrium to right ventricle. From there goes the pulmonary trunk, that is the pulmonary arteries, right and left. That thing will go into the lungs, from lungs, and then so this is the pulmonary circulation. Pulmonary circulation. And similarly, there would be the systemic circulation, which will be starting with left ventricle, and then the aorta to the body, and then back to say right atrium and ventricles. Right now we are not drawing the systemic circulation. We want to focus on this. So over here, we'll be dealing with three things. One, in fact, four things. The right ventricle, pulmonary trunk or the pulmonary artery. Those arteries, they'll keep on divide. They will divide. And actually, they will be moving on to the alveolar system. And over there will be gas exchange, and then they will take the oxygen and they will go the way. And these are pulmonary veins. These pulmonary veins from both the lungs, so they go out, and finally they drain into the left atrium. Right? This is the oxygenated blood, and that oxygenated blood. So this circulation, the pulmonary circulation, will now focus on this one. So when it is said, during COVID-19, have you seen that people say that in case if the oxygen concentration is getting low, so what position one must acquire? Ulta so jao, right? When you are sleeping like this, face up, so this thing is called as the supine position. And when person sleeps ulta, like this, the face down, so this thing is called as the prone position. Prone. It is this prone position which is extremely good, because that will increase the SpO2 level. So in other words, it will be increasing the lung perfusion. So let's see why This is so good. Second, whenever there is pulmonary edema, right? We talked about pulmonary edema. Pulmonary edema is very simple, right? This is alveoli. And when there is fluid in the alveoli, when there is a water in the alveoli, so that is what is called as the pulmonary edema. So this is a pulmonary. This is where the water is. So today we'll see this, and then we'll go all the way to the. So here it is. Let's say that's our lung. This is our right lung. And that's our left lung. In right, there are three lobes. The upper lobe, middle lobe, and the lower lobe. Over here, technically speaking, there are upper lobe and lower lobe. But there is one lobe which is called as the lingular. So you can say that lingular is like a middle lobe of. Now, these are the anatomical lobes. These are the anatomical lobes, but truly speaking, if we draw one that is bigger, and we simply divide, say as per distribution. As per distribution, that is the way how the air gets distributed. As per the air distribution, the zones are created. Nothing what is called as the zone 1, zone 2, and zone 3. So zones are created in the lungs. It has got nothing to do. So if I say that this is the right lung, right? So this is zone 1, this is zone 2, this is zone 3. No. It can be or it might not. Why I am telling this? At first we'll see that what happens when the patient is standing. What happens when the patient is supine? What happens when the patient is prone? Right? So when the patient is standing, when the patient is supine, and when the patient is ulta soya, that is the prone. So starting with standing, because when it is standing, the gravity will come into picture. Right? Gravity comes. And when the gravity comes, so it means if the blood is entering like this, and like this. So over here, the gravity is acting maximum. So there will be more blood over here, more blood. Because it will be straight away coming over here. And relatively, there will be less over here. Here it is midway. So that is simple. So we can say that is this zone 1, zone 2, zone 3? No. When the person would supine, so now the gravity is acting on the entire lung. Right? So it is the lower zone, upper zone, that's how. So they are now evenly spread. So that's the reason that these zones, they are not anatomical, but they are called as the functional. Right? They are the functional zones. And when they are functional zones, that means they are dynamic. Dynamic means ever changing. So even under normal physiological response also, there will be change. Especially when you take deep breath in, deep breath out, you start running, you start swimming. Right? So it happens. That there would be change in the zones. So let's start with our standard figure, where we drew that, okay, this is the alveoli, another alveoli, and we have those capillaries. These are the capillaries, which are taking part for the gas exchange. So this is alveoli, and that's a capillary. If I really talk about this blood is coming from, this is the deoxygenated blood. This blood is actually coming from right ventricle to pulmonary trunk. and then from pulmonary trunk to pulmonary artery and dividing all the way, then finally it is reaching. So this is one. The alveoli we have talked about. There is a space in between. There is a small space in this space. So that's a small space which is present over here. So this space is called as the interstitial space. Interstitial space. So today we'll be dealing with capillary, that is the blood, interstitial space, that is 2, and the alveolar space, that is 3. So let's make it still bigger now. So here it is, the capillary, pulmonary capillary, and this one is alveoli, and these are endothelial cells, right? Single layer endothelial cells. If that is the endothelial cell, then what is this? This is that fluid layer which is causing the surface tension, and that surface tension will be tending the alveoli to collapse. Right? So this is fluid, and coming back to this, our capillaries. In capillaries, capillary is basically blood. In blood, we have got the fluid component and there are cells. The fluid component, it is called as the plasma, and then there are the cells. At this point of time, cells, RBCs, we are interested in the RBCs because RBCs will be carrying the oxygen and carbon dioxide. Here is the plasma. The plasma is comprising of very important component, and that is what is called as the plasma proteins. Plasma proteins. These plasma proteins, whenever there is protein, the tendency of the protein is they are tremendously, they tremendously love the water. They are hydrophilic. So they will hold the water. They won't leave the water. So they hold water. The technical term for this thing is called as the colloidal oncotic pressure, or there is other name, what is called as the colloidal osmotic pressure. You come across any of the term, it's one and the same. So from this point onwards, we'll be calling it oncotic pressure, because osmotic pressure, we'll be using it for some other things. Oncotic pressure. Oncotic pressure is the pressure which is generated by the plasma protein. So what it will do, it will say fluid, no, you should not go out. It will say fluid should not go out. So it will retain the fluid. It will keep the fluid inside. And so this is the direction where it will keep the fluid inside. Proteins, they are very strictly controlled in our body. So their pressure is also very strictly maintained. It is plus or minus 0.5, 28 millimeter of mercury. So that is very nice. Next, we need to make this capillary like this, because in capillaries also there are cells, right? These are the single layer of cells, very tightly bound. So only some of the structures, some of the things they can really pass. Regarding these cells, RBC is okay, but when there is WBC, so normally WBC is there, they are going. There are platelets, right? They are also going. But we'll find that what happens when there is a clot, when there is some infection, and then the whole sequence starts. Lots and lots of things, they start into this process. So this is post pressure. First, we just talk about all the pressures. Then second, if the water is more, water has got tendency to just seep out through these spaces. Right? So over here, it is the fluid. which has got habit to go out. So that is the water or the fluid, and that is called as the hydrostatic pressure. Hydrostatic. So this hydrostatic pressure, what it will be doing is it will always be interested in leaving, right? Let's throw the water out. Let's throw the water out. So that is what it will always try to do. Now this hydrostatic pressure, that is again very much controlled, is about 7 mm of mercury. So this is the pulmonary capillaries. These are the pulmonary capillaries. Now pulmonary capillaries, they are bit huge. They are called as leaky. So some plasma protein that will always just leak out. Some, not full, but some plasma protein will always go out. And the area which is outside it, it is called as the interstitial area. It is interstitial area. So in this interstitial area, plasma proteins have landed. Plasma proteins, that is their tendency of plasma protein to hold the water. So what it will do? It will keep the water into this interstitial area. Not good. Not good. Because this is the interstitial area. If water starts accumulating over here, when we say that pulmonary edema, then pulmonary edema is once again subdivided into interstitial edema or alveolar edema. Makes sense? Whether the water has got collected over here, it is interstitial. If the water has got collected into the alveoli, it is the alveolar edema. Both the cases, they are called as the pulmonary edema. Right? Both of them. So that is the reason that today when we'll be understanding the differences between all of them, so we divide it into two parts. Idea is when you see the patient, you start thinking about that what questions to ask or what exactly to examine. So this is clear. Plasma protein is 1 and the hydrostatic pressure is 2, and this one is our the interstitial area. So we'll just write it like interstitial pressure. Interstitial pressure. Which pressure? Oncotic. Right? This is plasma. So that would be the oncotic pressure. So this oncotic pressure will always insist on one thing. Let's not let the fluid go out. Keep it here. So this is another 14 millimeter of mercury. Still, and this is also the pressure which will say, okay, let's take the fluid out. Right? So let's take the fluid out. So this is hydrostatic pressure. The direction would be this. Right? We try to go higher. This is also the direction. This direction. That is for interstitial oncotic pressure. This is for hydrostatic pressure. And then finally, in alveoli, there is surface tension. There is surface tension. And this surface tension is generating the pressure, which is about 8 mm. 8 mm. Mercury. So thus, we have come across 4 pressures. 3 pressures. 3 pressures, they are let the fluid come out of the capillaries. And there is only 1 pressure which is behaving against them, which is telling that no, fluid should not go into the lungs. Because if the lungs are loaded, it is like lungs, they themselves will be drowned into the fluid. So, which are they? One, which was oncotic pressure. Oncotic pressure. So this oncotic pressure, that is oncotic, we need to write here. We need to write oncotic pressure. We write it over, because it is keeping the fluid inside. So that is about 28. Then all the fluids. One is the hydrostatic pressure, which is trying to throw the water out. So that is about 7. Then there is interstitial oncotic, which is 14, and then there is alveolar pressure, which is because of the surface tension, that is 8. So 8, 14, and so 7 plus 14 plus 8. These are the pressures which are telling that yes, pulmonary edema should occur, right? Water should go out. This 28 is telling that no, water should be retained into the capillary. So what would be the number? Right? 14 plus 8, this is 22 plus 7, 29. 9. Over here, this is 28. 28 is telling that keep it inside. 29 is telling no, it flow. Let the blood go out. So this is, what would be the net result? Net result is 29 minus 28 is equal to 1 mm of mercury. Pretty less, right? Just 1 mm of mercury. Very less pressure. So pressure is pressure, right? Whatever we say, pressure is pressure. So this 1 mm of pressure, that will lead to what? Very small amount of fluid. Very, very small amount. Very small amount of fluid would leak. Actually, from where it will be leaking from. As such, we say that yes, these are leaky. These are leaky. So there will be fluid collection over here. So this small difference, and yes, actually it happens also. Fluid collection in space. When this is happening, this is what is called as the interstitial edema. Pulmonary interstitial. But we said that this is what normally happens. So if this keeps on happening, so collection of fluid into interstitial spaces, interstitial edema, that is fine. But if this fluid keeps on getting collected, gradually it will keep on mounting, and one day, right, the breathing stops. So this should not occur. So even if it is less, but it should not. So this fluid collection in interstitial space, by definition, we just call it pulmonary interstitial edema, but it never occurs. It is redirected like this. Redirected means there is a system what is called as the lymphatic system. Lymphatic system. This is an important system for immune disorders. So this system, lymphatic system, it will be draining this fluid and then it will put it in circulation into the blood. So lymphatic system absorbs that small fluid. And now things are good. So the lungs will remain clean. Lungs will remain dry so that they can do the gases exchange very effectively. From blood circulation system, it will go into the blood circulation. So this is how all these systems they work. If you have understood not much just this one figure, you can do each and every pathology in so much of detail, right, with complete clarity. So that is how we'll be discussing. Before moving on to that, when we said that okay, this is our lung, right? Let's say this is like my right lung, and this lobe was collapsed. So obviously, if one part is gone, to SpO2 level will come down. Won't these two take over? Well, there are some limitations. So for this, in one word, what it is called as the uneven distribution of blood. From one. So he said that in case of zone 1, there is less blood, and in zone 3, there is maximum blood. Don't confuse it with that this is 1, this is 2, this is 3. Because this thing is true only when the person is standing. So when the person is standing, this is what really happens. Here comes the pulmonary artery. It divides into 3 parts. Let's say this goes to upper lobe. This goes to middle. Start with the easiest. Lower lobe, gravity is there, so straight away the blood will be no hesitation. So it will be entering the lobe. When we say it is entering the lobe, actually what we really mean is that this is the alveoli of the body. And these vessels, these pulmonary arteries, and divide. Finally, it will be going like this. This is how it is forming. It is forming all the capillaries. So these are the capillaries. Basically, it is the pulmonary artery. That's why we need to understand that it is the pulmonary artery pressure, which so we'll just write pulmonary, say, that is one pressure. From where this pressure would be generated? Well, this pressure would be generated by right ventricle, because right ventricle is flowing. It is coming via right ventricle, then it is going all the way to the pulmonary trunk, to pulmonary artery, and then all the way to. So over here, its pressure was 25 by 8. That is in the systole, it was 25. So diastole, 8 mm. So when they divide, so can we really take, say, 25 and then we take the mean, the way we were taking the mean, it will come to about 50. Come to 50. This is the mean arterial pressure. So we come to 50. When it is coming over here, it is this pressure which is going into the form of pulmonary artery, and it is going to the upper lobe. Now consider this is upper lobe. And in upper lobe, we have picked up one of the alveoli. So we have now pressure in the alveoli. We have got pressure which is into these arteries. So this is the pressure in arteries. And on one side, we have got artery. And on other side, this will be the pulmonary vein. On one side, there is arterial system, second side, there is venous system, and in between, these are the pulmonary. These are the alveoli. So pressure 1, pressure 2, pressure 3. So now we are talking about the upper zone. Upper zone is working against the gravity. Upper zone is working against the gravity. And in this, the air will always be traveling up more. So air is traveling more. So there is more of the pulmonary alveolar pressure as compared to pulmonary arterial pressure. And the least one would be this is the up part. less blood is going, and due to that, say, and the alveoli, they are having air. Not only that, they will be in this is the situation. So alveoli, they are having maximum. Artery is low, pulmonary vein is still. This means that this particular pressure is low as compared to the alveolar pressure. So alveolar pressure will be giving the compression effect to these vessels. And when the compression is given, this will be the situation that alveolar pressure, this is highest. This is highest. In this situation, when there is more pressure right in between, so what is that DRT pressure? Which one? Achha. This part? Oh, it was 1. Not just here, this part. So coming back to this, think it like that over here in this artery, the maximum pressure is over here. This is maximum. Over here it is less, here it is minimal. So in this case, very less blood. It is never so that zero blood, but less blood will flow. Less blood shall flow. With the less blood flow, then we call it zone 1. Zone 1. As we said that zone 1, zone 2, zone 3, they are the distribution of blood across the lungs. This right now we are talking about standing. With supine and prone, things will change and we'll just see. So this is 1. What will happen in the middle lobe? Here comes the middle lobe. In case of middle, so deliberately we are not following. Those who are attending, who are present over here. When we, I told even before that also, that when we keep the recording, then we feel like, yes, recording is there. We'll see at a later stage. And then it keeps on mounting. It's better present, remain present. Say, even when I take those, live is definitely better. Even when I take my personal lectures, there is never a recording. It is like ask 10 times. Right? I'll take extra class to teach you, but no recording. We don't do that. Achha, back to this. In case of middle lobe, now the middle lobe is like this. In middle lobe, this is like a straight line, right? It is like a straight line. Straight away it will go. So over here you will get the benefit. And the benefit is like the pressure would keep on changing from the systole and the diastole. Systole and diastole. So in systole, what's the pressure? It is about 25. And in diastole, the pressure is about 8. So over here, this is a high pressure. This is a high pressure. So in systole, it would really happen that this arterial pressure, that is high, so it would be the highest pulmonary arterial pressure, then more than this pulmonary alveolar system. And venous, so it is always less. So here we have got the advantage. If the pulmonary arterial pressure is more, so yes, it will forcibly go out, right? And it will reach to the vein. So it will go. So here there will be the successful blood flow. No worries. Say even if, let's say, this is your first lecture, then the thing is we have covered lots of ground, right? Lots and lots of ground. It has been planned that somewhere after a month or so, that's right. So the first expression was how the pressure is distributed, right? That's what we saw over here. This is how the pressure is distributed. And now we are understanding that what would happen in every lobe. Actually, in standing, yes, every lobe, upper zone, upper lobe, lower, middle lobe, and lower lobe, how it will be distributed. Achha. Coming back to this, yes, for those who have missed many of the lectures, I'm planning to keep one revision session, which will be going at a very high speed. We'll revise everything whatsoever we discussed, right from the day one till that particular day. So we'll keep one session. I think we'll be keeping it in one of the week, where we'll be going for full complete revisions. That's what I said. That's what I said. If this is your first lecture, these lectures are for whom are these lectures for? Lecture is for you. That's why you are here, for all the first Mbbs, because we are learning the physiology. Achha. So this is one. And in case of diastole when the it is relaxing, so that pressure would be decreased. So possible that now the alveolar pressure would be more. So alveolar pressure would take over, and then the arterial pressure and the venous pressure. So in such system, there would be no flow. So whenever there is intermittent flow, that is slow, blood goes, stops, blood goes, blood stops. That is what is called as the zone 2. Zone 2, in which there is intermittent flow. Remember, again telling this, we are discussing as if the patient is standing, and then the patient, or even we can talk about us that we are standing, and then all these things are happening, right? But upper lobe is zone 1 and middle lobe is zone 2. No, it's not like that. Right? And actually, in a healthy, fit person, there is no zone 1. Right? There is no zone 1. Even some blood will always go. Finally, over here, this is like the lower lobe. Lower lobe, they are standing, that's why. And this would be when the gravity will come to picture. So gravity helps, and gravity helps tremendously. So over here, the pressure would be obviously in the artery, pulmonary artery, the pressure would be maximum as compared to even the veins, venous return, that would be better. And the pulmonary alveolar pressure, that would be less, because the air tends to go up, right? Air tends to go up. So over here, the pressure would be less. Gravity and the laws of physics. So here, the blood flow, that would be fantastic. And that's why this is called as the zone 3. So even in case of diastole, the blood will keep on moving. So that is the zone. The right one sentence, zones are dynamic. Zones are dynamic. That means they keep on changing. Every day they can keep on changing. Any increase in the cardiac output, whether it is because of any of the reason, if there is increase in cardiac output, heart is throwing more blood. Here is the cardiac output. So heart is throwing more blood. That is what we are talking about, right ventricle. Right ventricle is throwing more blood. So obviously the whole pressure would come up over here. As discussed last time, when the cardiac output increases, it opens more number of channels, right? It will open more number of channels. More blood vessels they will be conducting carrying the fluid. So collectively, it is like an increase in the virtual bore or the virtual caliber, what we talked about last time. So there is that increase. So if that thing happens, so the pressure is high. So even if there is any zone 2, it will be now be treated like a zone 3. It has improved itself because more channels open as the blood is going. Right? So blood with pressure will be opening even those blood small capillaries which were passing very less blood. Now more blood is coming. So for example, in exercise, when you do exercise, so the exercise, the way it is divided into one what is called as the aerobic exercise. So in aerobics, you are jumping, running, whatever you are doing, you are increasing the oxygen, but at the same time, you are increasing the cardiac output. When you are increasing the cardiac output, that means over here, these are all alveoli which are sitting. But now the blood is coming very rapidly, but at the same time, you are breathing also so rapidly. Right? You are taking deep breath. So it's a win-win situation. More blood is coming, alveoli are there, so they are loaded with air. So they just take that oxygen, gives carbon dioxide, and things go good. So this is that comfortable zone in which things are moving very fine. That's why the cardiac, this aerobic exercise, if you can sustain, so yes, it will improve. It will keep all these circulations better and better. Against that, there are other exercises. Say for example, strength training. Strength training. So in strength training, when you are lifting very heavy weight, so it is at that point where the blood is needed, the localized, those muscles, they are craving for more oxygen. So here, in case of strength training, specific muscles are involved. Let's say, still right now we have not yet decided, because I'll let you know about muscle training later. I'll let you know. Because in that training, I plan the training it in such a way, this is what is in my mind, that it would not be like just for physiology or for anything, it would be like that. Right from the beginning, till you clear your MBBS, not only MBBS, it is like till you clear that competitive exam, whether it is FMG or NEET or next, and even in your post-graduation admissions. This would be like this type of journey. Because in this, so what happens, again, no personal comments, but we are about, say, right now 120, which is a very small number. Some emails which are received, it is like people keep commenting that why are we learning in so much of detail, etc. My wish is not that chalo, you get good score in physiology, you get good understanding, so that the second year would be a pleasure, third year would be an absolutely lavish. Right? When your fundas are clear, you see the patient, you understand. Right? Passing of any of the exam, that would be like a cakewalk. Because if you have seen, right, by the way we are watching every time, we are watching 3, 4, 5, 7 X-rays. Till this time, you have seen more than 60 X-rays. Right? If you have seen that much, imagine you'll be watching during this entire course. Right? You'll be watching not less than 2000 X-rays, you'll be watching about 500 CT scans. With this much practice, right, you'll be able to diagnose the things so effectively. So that's the mission, but think it like this is a marathon. So that's why I never insist if someone comments, or some comments are also like that, I never speak on that. It's fine. This is what I want and this is what I do. You be the best. Right? Anywhere you go in the world, and no one should be able to. Because think it like when you will be coming back, you will be in direct competition. If you are doing your post-graduation in India, right? So then you are in direct competition with all those students over here in India, those who are studying, right? In all the best of the colleges, because it will be a straight away you will be into that competition. So if anyone thinks that if final MBBS mein padh lenge, boss, you are very wrong. Because in that point, it goes then it goes like driving. What are the conditions for pulmonary edema, right? So cardiogenic, non-cardiogenic, then all those mnemonics. Arey, gali nahi bolungi. But it is like start to those mnemonics. Just after half an hour, you'll be understanding, you'll be able to deliver a lecture on pulmonary edema. Not only that, you'll be able to diagnose. because at this point, without any tension, with comfort, you are learning. So that thing actually, like a good rainwater, it gets seeped, absorbed into your brain. And these these fundamental things are what is needed into final exams. And all these exams, none of the exams, they are like someone can just that ratification and then they can pass the exam. They won't be like that. USMLE is like one of them. Where you have to really see and you have to understand. Today, I'll show you just 2-3 X-rays. But those 2-3 X-rays will blow your mind that, okay, so many things can be seen in the X-ray. Well, it is simple X-ray chest. Yes, and you'll be watching those things only which you have already seen. But this time, it would be a combination. So that's how gradually I'll keep on adding more and more things. So this is what it is my mind. So yes, when I'll be starting those personal classes, it would be right from the scratch. I'll be starting from the cell. Though we have discussed this, because over there, it's like all the 19 subjects. All the 19 subjects. Now, in some of the colleges, they don't take FM, right? Forensic medicine. It is not part of their course curriculum. I still teach it because it is this forensic medicine that gives the thrill. Right? Being a doctor, when you see a dead body, how to say whether it is a murder or how to say that it is like a suicide. Right? Patient has been shot, and then there are signs of drowning also. So what thing occurred first? Whether he was shot, then he was put into water, or someone tried to trick the doctors that first the patient was drowned and then mare hue ko goli mari. Many times, if those things are done by different people, usme kisko saja, right? One who made him drown or one who shot him. Right? If the person is dead by drowning, so that means it is now a dead body. Right? If someone shoots the dead body, but then it is not a crime. Right? He will be getting some saja, some punishment, but it will never be the life imprisonment because he cannot be submitted for murder. Your comments, your statement, that would be so important. Ek ki jindagi bach gayi. So many real cases. So that's why forensic medicine is like a thrill. Okay. Right? So I think I answered all the questions. I'll definitely let you know, right? Very soon, within just a week only, I'll be going into all the details. So, in case of strength training, when it is localized blood flow, right? It is localized. Yes, definitely you'll be using your heart, lungs, but not as much as you are talking about in aerobic. That's the reason when we say that being a doctor, you should be the fittest person. Strength training, there are some isolated exercise. Isolated means when we are focusing only on one muscle. So there is a strap which is available, right? That you wear on the chest. And then when you keep the hands like this, so then the entire hand is fixed. And then when you take a dumbbell and then you do, so it will be like only the biceps, they will be on focus. But the moment you say, Arnold Schwarzenegger in his book, when he said that pumping iron, so if you just keep on moving your hands like this, then you are doing the curls. Right? So it will be involving multiple muscles, and that is called the compound exercise. Compound exercise. This is just a variation of it. Compound exercise along with aerobic, that makes you extremely fit. Okay, so this was the point that whenever there is increased cardiac output, more number of channels are open. When more number of channels are open, obviously, right, it is better for the human body. Now some accidents. So we now know two concepts very clear. One, 4 pressures. Oncotic pressure, that was because of the colloid, right? That is the plasma protein. Hydrostatic pressure, both these pressures, they were into arteries. Interstitial pressure, so this is 1, this is 2. Interstitial oncotic pressure, so that was the 3rd pressure, and then the alveolar pressure, that was the 4th pressure. So we know about this. And there is a gap of 1 mm, and that gap of 1 mm, right, that means some fluid will go. So because it is a gap of 1 mm, but we don't want even that 1 mm. Lungs are to be kept crystal dry. Then and then there would be a fine gas exchange. So that 1 mm of difference, it will generate some fluid, and that fluid will be picked up by lymphatics. Right? Will be picked up by lymphatics, and that is over here interstitial. I'll just show you over here. Let's put it here. Here. Right? So this interstitial fluid, right? So there is that gap of 1 mm. So that small fluid, small amount of fluid, right? Small fluid means small amount of fluid, that is picked by lymphatics. Right? Lymphatics, and it will be put into circulation. So everything now completely fine. Lungs are dry, right? And then they very effectively breathe. In pulmonary edema, very easy. When the water gets collected over here, or water gets collected over here. So in both the cases, it is called as pulmonary edema. When it is into the interstitial space, it is interstitial pulmonary edema. When it is alveoli, so it is called as the alveolar pulmonary edema. Okay. And the zones, right? These are the zones. What if you come across a patient who has got severe burns, maybe 60% burns, extremely dangerous. When we'll be learning in surgery, when we'll be learning that how the law of 9, that is the distribution. Right? Everywhere 9 goes. 10 areas, so it will make the complete 99%, and that's a 1%. You calculate this 60% burn. That means when there is burn, so much. Please mute. So this is 60% of burns, and there is so much. So there is, it is what is called as the hypovolemic shock. Volemic is volume. When there is decrease in the blood volume, so then body goes into the state of shock. So burns, severe dehydration. So volume decreased. If the volume decreases, so what would happen? The right ventricular output decreases. Right? Now think that it is not only the right ventricular output which is decreased, because the overall blood is decreased. Even the left ventricular output would decrease. When left ventricular output would decrease, it will give less blood to the brain. Correct? Less blood to the brain. So it is not only the lungs are affected, but it will the brain which will also be affected. It will be liver will also be affected. Right? Even the kidneys would be affected. So everyone will start participating. Kidneys would say, there is so much of less blood, there is so much of less fluid. Let's stop, let's not throw the water out. Brain would say that I don't know whether the kidneys will be knowing it or not, but we release ADH, antidiuretic hormone. So it is like a lightning call to kidneys that stop diuresis, right? Stop throwing the water. So kidneys say, I also understand, because I have got my own mechanism, pressure receptors. So they are telling that less pressure, that means less fluid. So I'm not throwing the fluid out. But it will say, okay, the command from brain has also come in the form of ADH, then you don't throw. So now kidneys will be very meticulously keeping the fluid in the body. So that's how the systems work. But now right now, we are talking about only the lungs. So we are dealing with the right ventricle output. When right ventricular output, right, that decreases, this means less blood everywhere. So that this is where the zone 1 starts developing. But even when the patient is standing, even when the patient is sitting, hypo means less. Volemic is volume. Right? Volemic is volume. Volume of blood, or you can say volume of fluid. The fluid in the body decreases. So this is what is called as the hypovolemic shock. So burns, dehydration, in all these things, there is hypovolemic shock. You must have seen that at times when people donate blood, and suddenly they get faint attack. There can be multiple reasons. Even by watching their own blood, they can get faint attack. Or again, when the blood is donated, so there is some volume loss, and if the patient's condition, if the patient say has not taken the proper breakfast, like has not consumed enough water, and might lead to that. And it's like patient is on that tilting point, and then goes into the shock. Suddenly they start getting blurred vision, they start getting fainting attacks, etc. Right? Okay, so this we understand. So this is where the zone 1 would develop. Zone 1 would develop. So when they say that zone 1 is developing, that means what? That there are some specific areas in which the blood is not good, or there is decreased blood flow. Right? Decreased blood flow. Classically, it happened even in case of, say, COVID. During COVID, let's say I talk about myself, right? This collapsed company, right? Collapsed. When they collapse, so what will go? No blood would go. So this thing will straight away go into zone 1. So we go into zone 1. Another thing, because the alveoli have collapsed, right? Alveoli have collapsed. So then that mechanism, the oxygen sensitive calcium channels, oxygen sensitive potassium channels, right? They won't work. If they are not working, so everything stops, right? So even the blood which was passing over through, that will also not go. In simple words, lungs would say, if there is no oxygen, so why to send the blood over there? So there would be the vasoconstriction in the lungs. So thus this area will become totally dry, right? No blood, no oxygen. So this is typical zone 1. Right? Pretty dangerous, but this is typical zone 1. So this is what occurs in standing. When in supine position, so there is even distribution. Now you know the reason that if someone feels that unable to breathe, right? Visceral sulado, retado, right? Patient lies down. So that there is even distribution. Now the gravity is helping them. But obviously the blood is not supplied, will not the cell die? Definitely they will die. Right? So when the lungs collapsed, and this is what has really happened in case of COVID, right? If it is just deviating slightly, but the question which you have asked, yes, that's true, that due to, say, all these factors, it starts developing pulmonary edema, there is a breathing problem, right? And the oxygen level starts going down. And at the same time, because if it is happening, at the same time, even the GIT is not supported. Person is unable to eat anything. It leads to severe deficit, and plus, say, antibiotics, heavy dose of antibiotics given. Right? In order to counter the infection, the steroid was given. Right? I took the steroids. I took the entire treatment at home, same by myself. So I took Dexona because there was no way out. It was falling rapidly. Right? So I had to take the Dexona. When I took the Dexona, right, steroids, so still it was not responding well. What body must have done? Body would say that brain and heart, they should really work. To hell with rest of the body. Right? So brain and heart, this is why people collapsed in COVID-19. It is like infection was there, but now what about the brain and heart? Right? They were not getting sufficient food. So gradually they start dying, and that leads to multi-organ failure. I lost in 12 days, I lost 14 kilograms. 14 kilogram weight loss, and that was absolute muscle loss. if you, I think on my channel, that picture is also there. That is on the day 28th when I recovered. So my students, they were every day they were messaging me. But on 20th day, I said, now I am fine. But it is like I was minus 14. Muscle loss, severe muscle loss. Because I got that body index checking. Rapid muscle loss was there. But the best is when the muscles break, they release large amount of protein. And it was that protein which was utilized by heart and brain, and I survived. So it leads to severe muscular breakdown, but at least you survive. So this is the reason why it is said that keep yourself very fit. Many people, this was the wave 2, which was one of the worst wave and got this infection. Always put the patient into prone position. This is again which was done severely during COVID. If nothing can be done, so then patient ko ulta sula. Ulta. So over here, it is best position. It is the best position if the patient is breathless. Right? Multiple reasons. One, this will improve oxygenation. The oxygenation is improved because see, when we are standing, right, or when we are supine. So during this stage, the abdominal organs, right, when person is standing, the abdominal organs, they are expanding, so they'll press the diaphragm up. Plus the heart is there, right? So the load of heart on the lungs, right, it compresses. When the person is ulta, prone, all the organs, the heart, now that is down, right? So no compression from heart. No compression from heart and abdominal muscles and abdominal organs. And one more very interesting thing, the posterior part of the lungs, they have got more alveoli. So it is the back part. You can say in very crude language, the back part of lungs, back part has more lung tissue. More lung tissue. So if the back part has got more lung tissue, when you are into prone position, so it means this back part is up. So that means the air which will enter, it will always try to go up. When it will try to go up, that means those tissues, they will be used more. So there will be the better alveolar function. And third, when the patient is like this, so the mucus secretion, because when the situation is bad, the mucus which is formed by the lungs, if it goes back, so it will be blocking some alveoli. In this position, so it will start accumulating into the mouth or it will come out. So there is better mucus drainage. This simple technique, it has saved so many lives. So even in ICU, bindas, patient put it to prone position, and then whatever the mucus which comes out, right, just put a suction and take it out. Person would be responding so well. So especially in COVID-19 and in any of the case in which there is ARD, acute respiratory distress syndrome, right? It is called as the acute respiratory distress syndrome. So when person is unable to breathe properly, and in this COVID-19, because COVID virus was affecting the alveoli, it was making the entire breathing difficult. So this is what really can happen. So this is for the prone position. Now let's see what would happen when things go wrong. So we talked about all these things. But what if there is accumulation? There is accumulation. And that accumulation is called as the pulmonary. Before we start for the pulmonary part, I will just show you those X-rays. Watch the X-ray, how they look like. This is a very classical case. Very classical. You can, as such, there are so many findings. See all these are the metal stitches. You see the metal stitches. Oh, there is one more thing. See, and I need to zoom it out. See. Can you see something over here? I just removed this. Can you see it? This is artificial valve. This is mitral valve. The metallic mitral valve which has been put. These are the locks, and this is the base. Then we'll be discussing congenital heart failure or congenital heart diseases. So it is at that point when we will see that in case of, say, mitral or tricuspid or into the form of atrial septal defect or the ventricular septal defect, how they can be repaired. I'll show you. So, but this is that must be the reason that these are the metal stitches. They must have done the thoracotomy. So, anyway, over here, see the pattern. This is the pattern. This is massive pulmonary. Massive pulmonary. Similarly, there are some very interesting things. Can you see this white line? See, over here. Can you see it over here? White line. I'm talking about this line. Can you see that? Right. This is aorta. There is calcification in the aorta. Right. Aged patient. See the septum. This is the septum, crystal clear. Right. Septum has been calcified. Even these are the curly B lines. So many findings. Cardiomegaly, heart is enlarged. Right. There is a right ventricular hypertrophy. We'll discuss this. This is a very good X-ray. So many findings in one X-ray. Right? Even the bronchial, normally you don't see the entire bronchial tree is seen. You see the outline. This will give you the understanding that how nicely, see over here, this, right? Can you see this? This is the trachea, all the way from trachea dividing into primary bronchus. Right? Out of the topic, one point, and this is like a USM question. Right? And they say that the patient has come to you, patient is a kid, right? And it has swallowed you know that marble, people play with those marbles, right? So that marble has been swallowed. So looking at the patient, kancha, exactly, kancha, yeah, that's right. So patient has swallowed that. No X-ray is given, nothing is given, just a question which is asked that in which lobe or in which side of which lung do you expect it to go? When person swallows, it will always be going into the right lung. Reason? See here, so wonderfully see. See the angle. It is this angle. Right? And over here, this is like this. Right? This is a smoother path. It will go into the lungs because patient has taken it into the trachea. it has gone into the trachea. Many times this is what is called as when any of the fluid gets swallowed. No, it will go into the right only because of the angle. The angle is one part which is like this and second part which is like this. Right? So it will go over much. See the caliber. Caliber is much bigger as compared to the caliber of this left. Left is at an acute angle, right? If it is at an acute angle, it has to really go like this. No, it won't go. And then things they roll, it straight away. In most of the cases, in 99% of the cases, it will be over here. Subject to if there is any anatomical variation, so then it is a different thing. But otherwise, any of the fluid which is swallowed, but the patients, when they vomit, so that goes into, they regurgitate into the lungs, and that leads to so many complications. When sometimes you must have seen that. What is drowning? Drowning is nothing, but we have got a wonderful mechanism over here, right? In the form of epiglottis. But it won't permit any of the air to go into the esophagus and any of the fluid to go into the lungs. But when person is underwater, right, and he tries to breathe, because in the desperation, right, it is an automatic phenomenon. The water trickles, water enters into the lungs. This is how person drowns. Right? It is like you'll find the water into the lungs. Same thing when patient vomits and if patient is unconscious, so then that mechanism won't work. Things are swallowed into the lungs. Diaphragm will be at the same level. Diaphragms are there quite okay. Normally this will be slightly lower, but not much of the difference. Fluid will also go in right lung, more in right lung, but it can go into the left also. But in most of the cases, whenever the things are aspirated, right, that is what is called as the things are aspirated, you'll find that in 99% of the cases, you'll find it is the lower right lobe. This is the area where you see that. Now, so there is one more. This it is still, but there is asymmetric pulmonary. We'll come back. So here it is the pulmonary edema, and we need to understand why it really occurs, where how it occurs. So it is like water in alveoli. So this is our purpose: water in alveoli or the interstitial space. Now, if the foundation is completely clear, you know about all those mechanisms, right? All those four mechanisms. Within 10 minutes, you'll be able to. We'll see the X-ray, right? Within 10 minutes, you'll be able to understand it. So let's start. Reasons why it can really occur. First thing, who is preventing? Which pressure is preventing the water to go? We'll see the X-ray, right? Now let's focus on this. Who is preventing the water to go out? Oncotic pressure. That's right. It is oncotic. Oncotic pressure depends upon the plasma protein. Right? Decrease the plasma protein and then the pulmonary edema would occur. Decrease the plasma. So plasma protein, it is not coming from space. It is something which is formed by whom? Liver, right? Because in our blood, right, it is the liver which is making that plasma protein. So plasma protein is formed by liver. So let's start with the easy things. One, protein, less protein in the body. So when can there be the less protein in the body? When person is not eating. So this is called as the PEM, protein energy, malnutrition. So when the person is not having enough protein, you'll find that they'll feel very tired, breathing like simply because that interstitial space has started it's putting the load. Body has got less protein, so this is how it is affecting. Very simple, right? Then, what if the protein formation itself is less? Less protein is produced. Liver is forming, liver disease. In liver, there are hepatic cells. So those hepatic cells, they are either destroyed, right? So whether there is any inflammation, so they are busy in solving that. They'll say protein will be produced later, or they are destroyed. So how do we say that? Whether it is hepatitis or cirrhosis or carcinoma of liver. So there is carcinoma of what is called as the hepatocellular carcinoma. Or there is liver cirrhosis, alcohols. So in all these cases, liver is not functioning. So plasma protein is less. Plasma protein is less, so that there would be that 28 mm of pressure which was to be generated. That opposing pressure has gone. So previously it was like 29 minus 28. Now this pressure has decreased, and let's say if it has become 24. So now the resultant pressure is 5 mm of mercury. 5 mm mercury is 5 times more water. Lymphatics, they won't be able to clear it. Then the trouble, the fluid accumulates. Very simple. So this is second. Third, this is where the less protein is formed. What if the protein is lost? Here there was less protein coming into the body. Here there is less formation of the body, right? Less formation of protein. Less formation of liver is producing the plasma. Right? See over here, oncotic pressure, right? Plasma protein, this is formed by liver. It is formed by liver. If the liver is bimar, so then there would be less production of plasma protein. Less production of plasma protein, done. The entire sequence starts because there is less oncotic pressure. Easy. The third point. What if the protein is lost? Protein is lost. Protein lost from the body. Now, from our body, there is one way where it can really lead to a major loss, and that is kidneys. Right? Normally, kidneys won't allow, right? But because in kidneys, this is the Bowman's capsule, and this is the Bowman's capsule, and these are the tuft of capillaries which are formed over here, right? And these are the afferent, and these are the efferent, and the pressure is generated. But the area in which we are interested in is called as the base area. It is this area. It is this area which is very finely designed, and it is called as the basement area or the basement membrane. So in this basement membrane, they allow only the water and some of the electrolyte to pass through. When the protein comes, it won't allow the protein to pass through. So that's why the protein is not lost, because this is our Bowman's capsule. And then all the way it goes down, proximal converter tubule, right? Distal converter tubule, and finally the collecting duct, and it goes and everything gets collected, right? And the urine is formed. This basement membrane won't allow any passage to the plasma. What if this basement membrane is damaged? What if it is damaged? It won't get damaged so easily. But there are some autoimmune disorders where it is called as the autoimmune disorders. So in these there is no other mechanism by which they can. So once it is broken and this break, right? So this protein which will be appearing in the urine. This is why when you'll be watching when you go for, you tell your patient that go for the urine, say there is the general routine, general checkup, and the specific checkup. Right? This is what is done in lab. What you will be watching that in urine sample, is there presence of protein? Is there any presence of protein? So if this is present, that means this is the loss of protein in urine. Loss of protein. This condition is called as the nephrotic syndrome. It is called as the nephrotic syndrome. So whenever the word, you will come across this nephrotic syndrome at so many places. But simply speaking, whenever this word comes, just understand the basement membrane is somehow broken. Now, whether the basement membrane is broken because of some congenital defect, or it has developed because of autoimmune disorder, or it has been affected by some poisons, whatever. Basically, body is losing protein. So that is what is called as the nephrotic syndrome. All these are collectively, they are called as the protein losing nephropathies. Nephropathy means kidney disease. Nephropathies. So body is losing protein and then dying. Now in this case, when actually this is happening, and this is the overall loss. So over here, what would happen? Say typically, if the question is sometimes asked that those who develop carcinoma of liver, if you'll see those patients, their tummies would be huge. That is what is, there would be fluid into that tummy, which is called as the ascites. Ascites. Fluid in abdomen. Now you might come across the problem is in liver. Fluid kahan se aa gaya? The fluid has come because the same mechanism is occurring at a mass scale onto the entire body. There is so much of less production of plasma protein, so much of less that literally the entire oncotic pressure has reduced. So that's why the hydrostatic pressure, right? It is booming and it is throwing the fluid into the, it is getting collected into the abdomen into the form of peritoneal fluid. Right? Similarly, you'll see the legs, they are swollen. The hands, they are swollen. Because wherever the tissues are, right, everywhere it is throwing them up. So this is the ascites, where the fluid gets collected into the abdomen along with the generalized edema. Generalized edema. And when that edema occurs, so you know it very well that now the patient's situation is deteriorating. So what people do, they tap it. Right? Put the needle and then the fluid is tapped. That fluid will come back again. Right? Till the plasma protein is not corrected, right? This ascites is not going to go. It will always remain there and condition will keep on worsening. Knowing these things, because when you start with albumin or when you start with plasma proteins, you see the condition of the patient drastically. Right? If it is a massive hepatocellular carcinoma, nothing more can be done. but at least the life, whatsoever it is, more comfortable. So much amount of fluid will be pushing the diaphragm up, person won't be able to breathe properly. When person won't be able to breathe properly, it will be generating so much pressure on the heart. Heart is taking load, right? So in that process, you'll find that so much of the heart is compromised that heart won't be able to pump the things properly. You'll find that the systolic pressure is falling. Right? When the systolic pressure is falling, that means that will lead to decreased perfusion to the brain. So person will be feeling sleepy, person will be speaking, babbling, right? Speaking something which is not making any sense. And this is how the whole chain of reaction goes. Just give one plasma protein and see what happens. You'll see the drastic impact. But this is the basic mechanism behind all of them. So this is third. One more. As we said, everything is. By the way, how many of us are still 99? Good number. I'm happy. In some of the lecture, last time it used to happen when, because today we are all a bit overboard, right? The number, but still I need more 10 minutes. At times, so there were like only 20 students. Then we had to stop those lectures. Just 10, 15 were there. So we had to stop that. 99 is good number, good one. On to the GIT. Logic. Use the logic. What if someone has got diarrhea? So much of protein is lost. So then GIT, it would become one of the bigger things. And whenever anything happens to GIT, it is called as pathi. Pathi means abnormal. And GIT is also called as the enteric system, right? So it is called as enteropathy. Enteropathy. Right. In this, divide it into two parts. One, erosive. Erosive and ulcerative. Ulcerative. When there is extensive damage, right? Say for example, gastric ulcers. So whenever there is so much of inflammation, the absorption is badly affected, right? Colon ulcers, or what is called as the ulcerative. There are multiple small ulcers, ulcerative colitis, that is in the colon. There are so many small ulcers. Crohn's disease, right? Again, it is massive infection, Crohn's disease. So they are like where there is erosion and the ulcer. Then there are some conditions, they are non-erosive. Ulcer in stomach, that is gastric ulcer, right? When it is like this is stomach. Gastric ulcer is stomach ulcer. Then these are non-erosive. So non-erosive means there is no ulcer. But say infection, bacterial infection or parasite infection, worms, right? Parasite infection, that means worms. There is so much of diarrhea that all the fluid and everything is lost. What is that fourth one? 1, 2, 3, 4. It is called as Crohn's disease. CROHN, right? CRH. So in GIT, we'll be studying all these things in more detail, but just giving you a brief idea. Then there is another thing which is called as the amyloidosis. Amyloidosis. Here, see, there is no damage to the organ. Right? Over here, that there was damage to the organ. Here, there is no damage, but still we are losing the protein because see, bacterial infection, massive diarrhea, massive vomiting. Parasitic infection, diarrhea. Amyloidosis. Amyloid is a protein. This protein gets built up into the organs, right? Various organs, it accumulates. So that leads to decreased plasma protein, right? Similarly, rheumatoid arthritis. Then there are conditions like SLE, systemic lupus erythematosus. These are the conditions which are like autoimmune disorders. So in that case, again, multiple areas they are affected. And one more thing, if we really add, and that would be everything is fine, right? All our hydrostatic pressure is fine. There is wonderful, say, oncotic pressure, interstitial pressure is fine. Alveoli, they are working. But that thoda sa fluid, that little fluid, right? What if the lymphatic system is wrong? Right? Lymphatic system. The lymphatic system is not taking even that small amount. So if it is not taking, then that fluid will keep on getting collected. And one day, massive. Right? So this is lymphatic system. So in case, so any of the infection to the lymphatic system or the lymphoma, cancer. Right? So when there is infection and lymphoma, so that lymphatic system will be busy. In fact, it would be working in a reverse way. It will say infection is there, open up the channels, right? So it will say capillaries, vendas, open up, right? Open up. So it will shrink these endothelial cells so that more blood can really pass. Because the idea is whenever there is inflammation, more blood is needed, because more blood means more WBC. They are our fighters so that they can fight the infection. But along with that, even the plasma protein is also good. So yes, it will lead to inflammation, it will lead to swelling, right? All these swelling. Why the swelling occurs? Swelling occurs because of that, right? It is the fluid accumulation starts, right? So there is edema, right? So whenever there is any injury, right? If there is injury, so then that portion, it gets damaged, break, and then we find swallow. So from where the fluid has come? It is because of endothelial injury. That plasma protein has moved. So now there is less pressure, which can really hold the water. So now the water has started accumulating and the water accumulates. So that is the localized view. When it occurs at a massive level, it is generalized, right? So this is how, say, in case of the lymphatics, when they are blocked, so then there is no one who can take it. And if there is inflammation, so then more fluid which is entering and it is leading to all these problems, right? So then when the permeability increases. Okay? So how the patient would really bouncer जा रहे हैं, should not. क्या समझनी? If you have understood all those systems, there should not be any problem. क्योंकि इतना clear तो अपने बात की थी. Right? So if this is the alveoli, this is one was the oncotic pressure, second was the hydrostatic pressure, third one was the interstitial pressure. यहाँ से it was the alveolar pressure. 28 was कि fluid बाहर नहीं जाएगा. 29 is the collective pressure. That means some fluid is getting accumulated here. That is taken by the lymphatics. That is absorbed by the lymphatics. So what if lymphatics are blocked? Fluid will accumulate. What's the big science? इसमें क्या bounce हो जा रहा है? Focus. It's good that you said, right? But this was pretty easy. You know? Okay. Clinical presentation, how the patient would present. Right? Or what are the signs symptoms? How the patient will be having first thing. When the fluid gets accumulated, what would happen? Fluid is accumulating into the alveoli, interstitial space. So, breathlessness, that's right. There would be the breathlessness. Technically, you can say dyspnea. Dyspnea. That's right. There would be difficulty. Then he'll be having foaming from the mouth. मुंह से झाग निकलना. Foaming from mouth. Why that? Because in alveoli, the fluid which is getting collected, body will try to throw it out. Right? So those cilia will be working to chalo pheko isko baar. So that thing, along with the mixed with the air, so when it will come out, it will be coming out in the form of the foam, froth, जो मुंह से झाग निकलना, what they say. So this would be the typical thing. What heart would try to do? Heart would try to do, chalo, beat fast, right? There would be the tachycardia. And in pulmonary edema, deliberately I have not taken one section. That is how the heart is involved. Because that is what I'll take the next time when I'll be showing you the X-rays of when the involvement of the heart also. Right? So this topic is not yet over because it is one of the massive topics. The cardiac portion we'll be taking next time. Acha. So right. So this is how the patient will really come up. Now we see the radiology. It is called as the bat, that chamgada. This is called as the bat wing appearance. Bat wing appearance. See, just look at it. Do you find like this the borders? Similarly here. Now I'll remove that and see it. These are the hilar shadows. These are the hilar. From hilar, see, this is how. And you will appreciate that bronchovascular markings, they are always still bronchovascular markings. They are normally seen till what? What level? Kahan tak? Bronchovascular markings. BVMs. 7? No. Not 7. That is what you are talking about. That is the diaphragm level, which is telling whether the heart is expanded. 2/3 of the lung. That's right. That's the answer. Right? Up to this level. Right? So if you divide it into 3 parts, so up to this level, normally you don't see the bronchovascular markings. So this is why this bat wing appearance that would be seen into the 2/3, because that is the area where there will be a collection of the fluid. Right? So this is why it appears like this. This is why it appears like this. So as if that bat, right, his wings, these are the bat, that is what it's called. It's the bat wing appearance. Right? Over here and over here. So this is one bat wing appearance. The heart is definitely enlarged. Right? There is cardiomegaly. To explain this, just take a minute. Cardio. This is the right heart. That means over here. These are the lungs. And the blood will be pushed into the left atrium to left ventricle. Right? And I'll write over here the right ventricle. Right? These are the pulmonary arteries. These are the pulmonary veins. The valve which is present over here is the mitral valve. This is clear, right? This circuit. When the heart is enlarged, for the reason there is problem in the mitral valve, mitral regurgitation or the mitral stenosis, or there is some conduction problem. Next time we'll be taking it in more detail, but say left ventricle is not contracting. In short, the blood is accumulating here because heart is, this pathway is for how the pressure would be transmitted to the lungs. So, right, what I've done is I've separated right ventricle and right heart and left heart separate. Are you just let me be clear. What I drew over here, this thing, is it clear to everyone? Any doubt in that? Pretty easy. The lungs are here. This is the right ventricle. From right ventricle, the pulmonary trunk will come. This is lung. From lungs, it is the pulmonary vein. Pulmonary vein will go into the left atrium to left ventricle. In between, there is mitral valve. But this much. Not clear? Where is the problem? Because then and then you will enjoy the X-ray. Otherwise, clear, na? Yeah. It's not this. Bye. Good. So, if there is accumulation of blood over here, why should be accumulation? Mitral stenosis, blood again is generated. Or mitral regurgitation, blood, it is throwing the blood back, right? Throwing the blood back. So regurgitation, in which the valve is unable to stop the blood, right? And blood is returning. So it means this left atrium is overloaded now. If it is overloaded, so that means there would be increased pressure. So then how come the pulmonary veins, which are already a low pressure system, they can put the blood into the left atrium? They won't, right? So it will lead to back pressure. That back pressure can be mounted. Because this back pressure will be doing what? It will be increasing the hydrostatic pressure. Because यहाँ पे these were the vessels, right? The oncotic pressure is the same, but this hydrostatic pressure, when the fluid will try to go forward, but it is unable, so that pressure will increase over here, and that will lead to pulmonary edema. Right? So thus, when we see the left atrial enlargement, when we see the enlargement, when we see the enlargement in this case, see how wonderful it is. This is what is called as the straightening of the left heart body. See the straightening of the left. Normally, you are watching the heart something like this. This was the shape. But when it goes like this, see, left heart border, see, bilkul seedhi. So this is when it is the indication that there is left atrial enlargement. When the left atrium is enlarged, that means all these things, they have occurred because of the back pressure, right? Back pressure. And this is the typical thing of pulmonary edema, bilateral, massive pulmonary edema. Because as such, even the whole heart size, that has also increased. This is like cardiomegaly, enlargement of the heart. Very easy to find out. Just take this maximum distance, right? Maximum distance all the way from here to here. Measure this maximum distance, and from here to here, take the maximum distance. If this distance is more than 50%, then heart is enlarged, right? This is B and this is A. So B is more than half of A. So then there is cardiomegaly. It is clearly seen as such. There is one more very fine. Here it is. This angle is called as the costophrenic angle, right? Costa means ribs. Phrenic means diaphragm. Costophrenic angle. Here also. But normally we see it like this. So on all those old X-rays, if you see, they are seen clearly. So they are called as the costophrenic angle. So these costophrenic angles, they are blurred. When they are blurred, that means there is fluid over there. When there is fluid, that is what is called as the pleural effusion. So that is what is called as the pleural definition. So this is the costophrenic angle, and this one is called as pleural definition. So that is what you see. There are some other findings also, what I told you about that mitral valve is seen, right? All those tracheal bronchial tree that is seen very prominently. See, one more patient. This is another patient. In this, a very prominent, this is calcification in aorta. So that tells us that patient is aged. Right? So much so that they have not removed everything. This patient must be in that, definitely. This patient must be in ICU. Because you can see that, see the ECG. These are the ECG connectors. See here. Can you see? ECG connectors, they are lying over. Here it is. Here it is. All those ECG connectors. Even the oxygen tube is also there. See? All the way from here. Right? See, this is the oxygen tube. And this oxygen tube. This trachea is shifted. The point to note in this is, on this side, there is clear battering of this. On opposite side, so this is a case of asymmetric battering shadow. Right? These are the asymmetric battering. All right. We stop at this point. Next time, we'll be taking some part of the cardiac system, something which is more involved into pulmonary edema, and then we'll move on to the next topic, in which the calcification of aorta is complete. Calcification of aorta, that is abnormal. Yeah, trachea is moved. Yes, that is minor. This is because of the pressure of it. Trachea is as such, this is like insignificant. It is not so that it will develop in every case, but sometimes it is seen in the aged patient, even without any pathology. Costophrenic is, this is the angle which is present over here. The angle which is present over here. This angle, this angle. The angle present over this one and this one. 4 angles. Right lung, left lung, heart. And this is diaphragm, so it is called as the, another name of diaphragm is phrenic. And these are costas. Costa means rib. Right? Costa. So now we need to name. The name of this angle would be, this is the angle which is formed by the ribs and the diaphragm. So we'll call it costophrenic angle. Costophrenic angle is the lowest angle into the chest. So costophrenic angle is this. So this is right costophrenic angle, and this one would be the left costophrenic. That last point. What name should we give to these angles? These are the angles which are formed by the heart and the diaphragm. So they are called as the cardiophrenic angles. Cardiophrenic angles. Then right. Okay. So today it went like a USMLE lecture. Because USMLE lectures, they are all of 2 hours. Flat 2 hours. No compromise. Don't worry. All right. Thanks a lot. Thank you so much. We should have a great weekend. So enjoy and see you soon. Thank you. Same to you.